I want to thank everyone for joining us for today's webinar, which is called Empowering Older Adults with HIV to Manage Their Health. I want to thank everyone for joining us today, as well as our incredible speaker, Dr. Stephen Karpiak, who's going to be giving us an incredible presentation today. I'm quite sure that there's a lot of information for us all to learn. So we're going to go ahead and get started, and just to let everyone know, you're on a global mute, so at this point, no one will be able to visualize or to speak at this moment, but once we do get there, you can always use the chat feature, and that will be the best way for you to engage with us in our presentation. So let's go ahead and we'll introduce our speaker.
Hello, everyone. Today we have Dr. Stephen Karpiak. He's the Senior Director for Research at ACREA Center HIV and Aging at GMAC. For those of you who are not familiarized with ACREA, that's Research Initiative of America, and GMAC stands for Gay Mental Crisis. It's one of the oldest and biggest organizations in the world, HIV and AIDS organizations. After 25 years doing research in neuroscience and immunology, he retired from Columbia University, and thus Karpiak next engaged in community-based HIV work. He was the executive director of an providing Congress housing for homeless living with HIV and AIDS. Returning to New York City, he was the executive director of Pride Senior Network, which focused on aging LGBT issues, and later joined ACREA in 2002. There he launched the ROA study, a groundbreaking research on older adults living with HIV, and supervised clinical trials for HIV medications. His research brought HIV and aging onto the national radar, resulting in the establishment of an HIV and Aging Awareness Day, the White House Conference on HIV and Aging, and the U.S. Congress and Senate hearings. As a member of the Einstein Rockefeller Hunter Center for AIDS Research, the HIV/AIDS Initiative of the American Academy of HIV Medicine, and the American Geriatric Society. He's also a member of the United Nations Aging Committee. Stephen is also on faculty at NYU and has published over 150 peer-reviewed scientific papers.
And definitely want to thank Dr. Karpiak for presenting with us today. And just to make sure that everyone understands how to utilize the chat feature, everyone's line's been muted. You should have a little line there through the GoTo training interface. So if you have any questions, and I've seen some people already saying hello and having a few chats in the chat box, but if you all have any questions about the content that Dr. Karpiak goes over, you can go ahead and type that in the chat feature there. And just as a reminder to let everyone know that the training is being recorded and will be accessible after this webinar has concluded. So thank you all so much, and with that, we'll send things over to our speaker. Dr. Karpiak, are you there?
Yes, I am.
Wonderful.
Great. Well, thanks, first of all, to NMAC for the invitation to present on this topic area, which is near and dear to my heart, really, from my introduction. There are many other people who help me in my work and research. We certainly don't do this alone. But my thanks to ACREA in the U.S. To begin, I've been doing research in this domain for the pandemic is going to dominate this in North America and Europe, and to some extent already in sub-Saharan Africa is being dominated by the older adult population. And now I can't see my screen. Hold on. Okay. Next slide, please.
Yeah, there's a bit of a delay on our end, so we'll go ahead and we'll see it in just a second.
Okay.
But you can go ahead with the content.
Oh, okay. So today I'm going to kind of walk you through kind of the history of the health status of the older adult with HIV, and give you a sense about where we were and where we're going. For at least between 2020 and 2022, 70% of the entire HIV and over. By the way, why did we choose age 50? I didn't make that choice, but some of the NIH did. The mean between 1 and 100 is 50, the midway point, and that's when everyone gets their AARP cards. The older adult today with HIV is more often to die from a non-AIDS related illness. And most of the time spent by HIV treating physicians or ID physicians is spent managing health other than HIV. This became evident in the late around 2009, 2010, and is increasingly the case today. Multimorbidity is the rule and not the exception in this population. Multimorbidity means having 2 or more chronic diseases. HIV is one of them. So a person, regardless of age, already has one of those conditions if they're already HIV positive. The management of multimorbidity is very different than managing HIV. The focus has heretofore been on, of course, viral load and CD4 count, adherence, etc. You all know that mantra, but today we're in a very different place when it comes to care. Next slide, please. So where are we going today? I'm going to give you some numbers. I'm going to tell you what multimorbidity means. I'm going to talk to you about how risk for multimorbidity can be managed and why we are encouraging the embracing of geriatric care principles and where can we go from that point. Next slide, please. Next slide, please. I always use the phrase, it's the numbers, stupid. If you don't have numbers, no one's going to pay attention to your work or what you have to say. This is the data from New York City, my hometown, where it is unusually cold. I'm not sure why. And we, in 2017, now have 57% of our entire population of people living with HIV are now age 50 and older. That means here in New York City, there are approximately 70,000 older adults with HIV, which is a huge number with all kinds of diversity and challenges. Next slide, please. Is being seen in many communities throughout the USA, some a little faster than others. Next slide, please.
Switched on our end. We're still waiting for it to update globally.
Okay, so all the numbers are not shown here, but nonetheless, for example, in San Francisco, they're already at 64 to 65% over age 50. As I said, New York City, New York State, we're at 56, 57%. Baltimore, 52. I know that Miami's just at 50. Boston, about the same. Next slide, please. Among the older adult population are the long-term survivors. Thanks to many advocates, we're hearing more and more about this group. All older adults are not long-term survivors, but all long-term survivors are older adults. The best estimates we have about what percent of the population are comprised of long-term survivors come from statistical data from New York City, and as well as the government. And it's about 25% of the entire population of people living with HIV are long-term survivors, being defined as being diagnosed before 1995 or 1996. So that's kind of a range, but we should be aware of them because they may well present with unique issues and unique problems that are different than the larger HIV and aging population. Next slide, please. This is just a summary slide of where we are in the USA in general. There are many predictions that we'll be at 70% over the age of 50 by the end of this decade, which is remarkable. As I say to many people, the aging population will dominate, listen to my words, dominate this epidemic if it's not beginning to do so already in Europe and here in North America, but also it's beginning in sub-Saharan Africa. Next slide, please. This slide shows the mortality rates in the HIV population in the USA. I want to bring your attention to a few things here. Number one, of course, mortality rates have dropped significantly since the introduction of ART. And there are disparities, clearly. We could see them here between the African-American, Hispanic, and the white population. They are significant, and I'll mention them again later. But nonetheless, the death rates have really markedly dropped, and we haven't seen any significant uptick in the last decade, even among those who are over the age of 65. Next slide, please. This is a more graphic representation of that data. If you look at the gray bar and the black line at the top, this is the number of deaths occurring over the last 10 years. If you look at when they occur, they are really, if you look at the yellow bars, they're occurring in the older population, those that is people over the age of 60. And if I had the data more precisely, it's really over the age of 70. Whereas the 50 to 60-year-old population, their mortality rates have stayed fairly constant and level. That's the blue bars. This is good information. Needless to say, everyone is not going to live forever. There's a point where we meet that door, and we're seeing similar patterns in the general population. Next slide, please. So as I mentioned before, the HIV treating physician or nurse practitioner or whoever provides clinical care are spending more and more time on non-AIDS related diseases. And as I mentioned before, the vast majority of deaths are not attributed to immune dysfunction. Next slide, please. So the comorbidities, or those illnesses which are largely associated with age that dominate this multimorbidity, are one, cardiovascular disease, followed by cancers of many types, bone fractures or osteopenia, and liver failure, kidney failure, frailty, which is an age-associated disorder, as well as cognitive dysfunction. Next slide, please. Here's a more specific list to which I've now added metabolic disorders, diabetes among them, macular degeneration, and hearing loss, both in the high and low frequencies. One thing I want to point out here is, though, that every person, older adult, living with HIV does not experience multimorbidity. Many do, but not all. That will change as the population ages, but it's suffice to say that many people, the only illness they're dealing with is HIV. Next slide, please. So where does this increase in multimorbidity come from? The term increased burden of disease is used when describing this population. It's believed that it's largely due to inflammation. The inflammatory response is a defensive response by the body, and it occurs from day one when HIV infection occurs, and it goes up actually rather high. That inflammatory response or cascade can be tampered or reduced significantly if people are on their anti-HIV meds, but it never goes away. That is the inflammation due to HIV. There are other sources of inflammation, and if you want to lecture on inflammation, I can do that, but if I start today, I'll not be finished till next Friday. So these are some of the sources of the inflammatory cascade. Next slide, please. Not only in the HIV population, but in the population at large, is well known that these diseases, from death, from cardiovascular disease, certain cancers, certain blood diseases, diabetes, cognitive dysfunction, frailty, are all a result of inflammatory response, which is continuous and beyond what one typically sees in the body. Next slide, please. Again, this reiterates the point I just made, that from the initial HIV infection, the inflammatory cascade is increased, and it is not stopped, but only blunted by HIV treatment. Next slide, please. Here are measures, biomeasures of the inflammatory response. There are 4 of them here. And these are all people from a population who are on treatment, and nonetheless, and for quite a period of time, and nonetheless, these markers remain elevated, even though they have suppressed viral load. Next slide, please. Now, this slide is just here to illustrate what we see. There are many, many, many studies that follow the same pattern based on large numbers of patients. But you can see that if you look at the red bar, which is in 2003, and the gray bar, which is 10 years later, you can see the increase in the incidence and the frequency of any one of these disorders. The first is cardiovascular disease. Second is renal impairment, which is very significant. Fractures due to osteoporosis, hypertension, diabetes, obesity, hyperlipidemia, which is also related to diabetes. You can see large increases in this because the population is aging. That is the variable that's changing here. Next slide, please. So, inflammatory cascade, inflammation, okay? Possibly ART toxicity. The early ART drugs were more toxic than they are today. And lifestyle are all contributors to these spectrum of disorders, which are largely associated with aging. So this may be true, except for ART toxicity for the general population, but it's also true for the person living with HIV. Next slide, please. As I mentioned before, the word multimorbidity is going to be used throughout this presentation. It's a word that one rarely hears unless you're in the domain of geriatric medicine. But here is one study which showed that the red portion of the graph are the frequency of people with multimorbidity, that is 2 or more disorders. In this case, actually it's 3, and the 2 is the orange. And you can see how the HIV population has a large number or increase in the incidence of multimorbidity. Multimorbidity management is going to become the key feature of my presentation today. Next slide, please. This is data from our work, as was mentioned, the ROA study, which we did in 2005. And you can see here, we compared ROA, red, to the green, and Haynes. This is general population data, a sample taken from the random sample done in the USA. And once again, you can see that the number of people with 3, 4, and 5 comorbidities is very, very high, as well as 2 in the ROA HIV positive older adult population. Next slide, please. Okay, next slide, please. So the first question I want to answer, and I'm sure someone out there will ask me, are older adults with HIV experiencing accelerated aging? This is a hypothesis. Many, including ourselves, thought maybe that's what was happening when we were around 2010. But as more and more data comes in, this is not the case. Next slide, please. What we are seeing is on the right graph here. instead of these multimorbidities occurring earlier in the HIV population, they are occurring with higher frequency. And those are really two very different things. And that's to tell you, I sit on many august group of researchers in the USA and globally. If the HIV population were experiencing accelerated aging, researchers would be beating a path to our door because it would be an extraordinary model by which to study aging. But that's not the case. It might be because it's a hypothesis, but it's yet to be proven. You know, there are very, very few medical models of accelerating. One of the problems that this hypothesis points to is that if someone asks you're 30 or 65 or 90, that is your chronological age. But we have yet to find a marker that tells us what is your health status. Fine. Next slide.
Do you want to go ahead and just discuss the content of the different graphs that would be there?
Since I don't know what the next slide is, if I want to go back and just talk about accelerated aging, I think that one of the reasons it's important to not say that we have accelerated aging is that we can engage in self-fulfilling prophecies and or become stressed out by this information. This is summary data from one of the major researchers in this area. And if you look at the curves, these are comparing HIV to the normal population or general population. You can see that when the morbidity occurs, it's not earlier, it's just more. Next slide, please. So the conundrum is what is happening as the aging process moves forward. And by the way, the aging process is a very complex system of events. And how does that interact with HIV? To be frank, we don't know the answer to that yet. And I also might suggest that for those of you who work in this domain, be it a service provider or researchers or whatever the domain, it's really important to engage people who work in aging. And people in HIV, they know their data, they know their information, they know it well. But most do not understand aging. And there is a whole world of people out there who work in aging. And they understand this phenomena far better than any person in HIV. It's been my goal to bring on people that I work with who understand aging. And it's imperative that HIV folks, from a service viewpoint, work with aging service providers. They get it. They've been there. They've done it for their lifetime. We need to use them as a resource. Next slide, please. And this alludes to an article by a couple of leaders in HIV, and it states very clearly that premature aging or accelerated aging is only a hypothesis. I don't want to minimize it, but it's yet to be proven, and there is actually very little data supporting that. What happens often is someone will do an experiment, they'll report it, it's a good study, but it's really based upon small numbers. And to see accelerated aging requires large numbers, which largely are derived from large populations across many hospitals or providers of care, or from the Veterans Administration. Next slide, please. So what are the factors that contribute to multimorbidity? So for any person, but in this case, for a person, older adult living with HIV, we have age. We know that morbidities increase as we age. It's a given. We observe that in everyday life. Sex. Females are better suited than males. There's more of them. They seem to be in better health in general, and they seem to have fewer frequency of these chronic conditions. And there's good old genetics, of which we have no control whatsoever. So these are factors that predict or load onto multimorbidity. On the other hand, there are life factors that can be modified that are significant contributors to multimorbidity. They include weight, obesity. If you smoke, example, almost 50% of the older adult population with HIV smokes. In most cities, like in New York, in the general population, that number is down to 13%. That is a huge difference. Alcohol, I'll show you data in a moment, but even a few drinks are not advisable for the person living with HIV. It might be for a person without HIV, but it doesn't work. Data now shows for the older adult living with HIV. Alcohol is of particular interest because it is the drug of choice for this aging population. And of course, there are the illicit drugs, largely party drugs and opiates, etc. This population does not exercise well. Of course, the general population doesn't either, but by comparison, their exercise is very, very low, which likely exhibits or a way of looking at their social isolation. They tend to be very non-mobile. Their diet is poor. Diet has to change over time as we age, but because of largely socioeconomic conditions or lack of attention, their diet nutrition is very compromised. And of course, always adherence to art is essential to mitigate the increased inflammatory response that occurs. So these are all things that need to be changed. If you are experiencing multiple clinical conditions, chronic conditions, you need to look at these behaviors, because the HIV component is controlled by heart. So its contribution, if managed, is actually very small. Next slide, please. Now, this slide lists very specific conditions that are defined as risks for multimorbidity. And I've mentioned them before, but I'm sure you're going to get a copy of this. It's important to look at them and to remind not only yourselves of those of you who are living with HIV, but those who provide services. That's really important to address these primary issues, because they will make a huge difference in your health outcomes as one ages. Sometimes they can be addressed with ease, but others take a little bit of focus. Now, these are all things, by and large, that are not easy to change. Anyone who's had to change them knows that. But it's important to change them if you want to change your health outcomes. You know, it's estimated now that a person with HIV will live a quote-unquote normal lifespan, which is just about over 70 years of age. That's an estimation. That's not based on case study. And if you expect that to happen, or better, these things need to be addressed. Next slide, please. So here's some data that you might want to share with some of your clients, or look at them yourselves if you're smoking. HIV positive men lose almost 8 years off their life expectancy if they smoke. They have almost a double chance of death compared to non-smokers, and they have a very, very elevated risk for cardiovascular disease. This is unquestioned, and this is true in the general population. And this is also true for non-AIDS-related cancers. The elevation is almost 3 times higher for those people who have HIV and smoke. These are very, very, very telling statistics. Next slide, please. This is data on alcohol abuse, and it's kind of interesting in that alcohol is related to, it can be related to actually increasing one's risk for HIV infection. We all know that, but its impact on the health of the older adult with HIV is really, really, really significant. And the work done by Amy Justice out of the Veterans Aging cohort, the VAX cohort, which are huge numbers, like 35 to 50,000 patients. And within the Veterans Administration, they have excellent controls, which are very hard to come by. They have found that even that one drink a day is probably to be avoided. Next slide, please. This is just a summary data from an article in the New England Journal of Medicine. And it shows very clearly, as do many studies, that healthy aging requires you to exercise and to diet. And when I say diet, it doesn't mean reducing your caloric intake, although it's not a bad idea, but it's also eating the right foods. You know, if you look at anyone who's morbidly obese, accumulation of fat in certain parts of the body or all parts of the body, that fat deposit is a source of inflammation. It generates inflammation in and of it by itself. And as I said before, the more you increase inflammation, the more likelihood you're at higher risk for any number of those disorders that have been listed. Next slide, please. This shows the what happens when the alcohol use, pretty heavy alcohol use, is used, how the CD4 count declines. And CD4 count is a measure of the function of the immune system. So the more we compromise that immune system, which has already been compromised, even when you're on ART, the more likelihood you're increasing your risk for those multiple chronic disorders. Next slide, please. This is from the ROA data. It shows the substance use in older adults with HIV. This is a sample of 1,000 New York City older adults with HIV. And you can see that over the lifetime, there's fairly high uses in some of these categories. And then it goes down as one ages, which is what's expected or what you see in the normal population. But if you might notice, the substance of choice is alcohol and prescription painkillers primarily. This changes by function of where you live and what circumstances you live in, but nonetheless, substance use continues in this population. It's interesting that for older, this is known for older men with HIV who have largely abandoned use of substances, but as they get older and because of their social isolation, they begin to use those substances again because they allow them access to younger people who have who are not HIV positive. So it's kind of like if they pay for it, other people will come. And this is really an issue about their social isolation because they have few outlets to engage back in society. Next slide, please. When we did roll it, for me, one of the most compelling pieces of data was this right here. The percent of the 1,000 people who were in recovery. So anyone who's been in recovery or knows someone in recovery knows that this is a lifestyle change, a significant one. And for those who can sustain a recovery, it is an achievement to be lauded. You can see here that the proportions are considerable. If you go into the general population, these numbers drop to generally less than 15%. This is one of the things that differentiates the older adult with HIV from the larger older adult population. Next slide, please. I'm going to move on here to mental health issues. In our study and in others, we have found high rates of depression. In many cases, it's been diagnosed, in some cases not. I was a professor in psychiatry and neurology at Columbia Medical for 25 years. It is beyond my imagination why depression is not being well managed in this population. There are many reasons why. You can speculate all you want, but the reality is this is a treatable condition, and it must be treated because people who are depressed have shorter lifespans, or even worse, they have much more complicated health problems. Next slide, please. This is, again, data from ROA, which is the orange bar. This is a percent compared to general population data. On the left happens to be the USA. On the right is New York City. Look at the rates of depression we see in ROA, 62%, 52%. I mean, it's 1 in 2. And anyone who knows or interacts with the population knows this is reality, whereas in the general population, it's below 20%. This is, when I speak and have conversations with older adults, this issue rises to the top all the time. One of the things, when studies that we've done some telephone interventions on depression, one of the things that fascinates me are the number of people with HIV, older adults, who are on antidepressant medication or engaged in some type of verbal therapy, and they're still depressed. Well, I think that if you're still depressed, you should talk to your physician and say, hey, this is not working. If it doesn't work, you have to speak up. Depression can be managed, and I think there's now increasing evidence to show that people are engaging this. Next slide, please. So depression is related to non-adherence. That literature is rife with this observation. So I suspect that many of the people, when you look at the treatment cascade that many of us are familiar with, that many of those folks who do not achieve suppression, or very specifically sustained suppression, have depression, anxiety, or some other mental health disorder that needs to be managed, because you won't get down to suppression unless you take care of this issue. Next slide, please. Now, this is data from Dr. Meredith Green and her group at the University of California, San Francisco. And these are syndromes that are typically looked upon by the geriatrician, not by the general practitioner. And as you can see here, everything from frailty, low percentage, to difficulty with IADL, which are a task of daily living. These things all are part of what a typical geriatrician workup will look at. Urinary incontinence, falls, most of which occur in the home. This is what they are concerned about, and they represent the focus of geriatric care, meaning function, day-to-day function. They want to keep people as independent and functioning as possible. That's the goal. It's not to cure disease, but it's to keep the person functioning in society. Next slide, please. As you increase the number of disorders you have, you will, as a consequence, be taking more and more medication. And the issue of polypharmacy becomes paramount. Every time you take a pill, you lose something. There is always a risk. And the more pills you take, the more likely that there will be a bad interaction. In this study, which looked at almost 15 people with HIV, you could see that 33% of them who are over the age of 50 had what were, on paper at the very least, likelihood of poor interaction between meds. And these are prescription meds, by the way. If you look at what's in a person's medicine cabinet, and I've done that, have a person bring in all their meds and prescription meds, it's shocking about how much drugs they have available and how they all can sometimes interfere with each other. You have to be very careful of this. The person who knows probably most about this is your pharmacist, which is why you should get or try to get all your medications from one location. They are probably the most educated on this issue of polypharmacy. Next slide, please. Polypharmacy is more is not always better. So HIV, is HIV the risk factor here? Yes, it is, but not as much as we might think. There are other variables, psychosocial variables, that need to be given consideration. And this is something that geriatric medicine does. Next slide, please. You saw on the list frailty. Frailty can be defined by certain functions, how fast you walk, your grip strength and things like that. But a geriatrician will tell you when they see it, they know it. Okay? That doesn't help us researchers, but nonetheless, frailty is the diminished reserve that we have. Example, if you're 20 years old and you fall down, let's say you break your ankle, okay? You will recover fairly rapidly. Okay? If you do that when you're 50, it will take a little more time. If you do it when you're 80, it will take a lot more time. And if that fracture is a hip fracture, a major bone in your body, that trauma can not only hospitalize you, but also lead to death. So this is the reserve. You may not even see it. I get very angry when I'm with someone and they say, oh, that 80-year-old woman, she looks like she's 50 going on 55 or whatever. No. You have no idea what her reserves are by what they look like. You don't know what happens when a trauma occurs, or even in an auto accident, or another major bout with a disease, or like the flu. It takes more and more time to recover. Every time that happens, you keep diminishing the reserves of the body to fight against infection or trauma. Thus, frailty. Next slide, please. So we mentioned this pattern before, and I want to talk about social isolation for a second. Social isolation in this population is massive. People are lonely. They are isolated. Why? Because of stigma. Because they are depressed, and they are therefore not being treated for depression, so they, again, collapse onto themselves and do not engage the larger open society. Social isolation is a serious issue. When we talk to many older adults and we say to them, what is your greatest need? We don't even give them a choice. 80% say social isolation. It's like they know it, they understand it, they're lonely, they need to be integrated back into their larger society or some type of social support. This is a key factor. In fact, social isolation also predicts the outcome of the aging process. If you're socially isolated, your arc of aging well is very good. Is not very good. Some people, on the other hand, some like to be alone and be isolated. That's a very different story. But in regards to social isolation, I think it's incumbent upon the person, the older adult living with HIV, to form little local units to overcome this isolation. AIDS service organization or CVOs are hard put to address these very individual type needs, but there may be some answers. But this is a major issue in this population, and it needs to be addressed. Next slide, please. So what I've been talking about is social variables. These are not medical variables. And these are variables that, by and large, an HIV treating physician, ID doc, or even a typical physician don't think about or care about or have time to even think about them. But in the aging populations and in the HIV aging populations, these are critical issues. They're not just, oh, it's, like, oh, it's too bad that we're socially isolated. Well, you know what? If you want to improve the health of this population, you have to start thinking about it. If you want to improve the health, you have to start addressing depression. If you want to improve the health, you have to somehow begin to get this population engaged again, because they've been socially isolated ever since HAART came along in the mid-1950s. End of the last century. So we kind of like, oh, HIV is treated by a pill. That's great, fabulous. But what about all these other ancillary things? They may not have been so important when they were younger, but they are today. And for the geriatrician, these are paramount issues that they address, and that when they engage the person with HIV, they ask about these things, which are typically never asked by the primary care physician. Next slide, please. So one good example, in most older adults live alone. 70%, this is a number we have seen repeatedly, not only in our literature, but across all literature. Next slide, please. In this next slide, we assume that everyone has a partner or is married, particularly as marriage rights were granted to the LGBT population. Not true. You compare that 80% of the older adult population is neither partnered nor married. So you don't have someone around you to make you take your pills or remind you to take your pills or pick up your shoes so you don't fall, et cetera, et cetera. It's a very critical difference. Next slide, please. So this comes to multi-morbidity management. How do we do this? Next slide, please. In this past year, 2 editorials in major medical journals made the observation that we are at the birth of geriatric HIV medicine. This may well be true. In fact, it is true. How this takes us into the future is questionable, however. Next slide, please. You know that there are not enough geriatricians to go around under any circumstance in the general population. And in fact, the number of people choosing geriatrics as a profession goes down every single year. And yet we live, for the first time in history, in an aging society. We need more and more geriatricians, but there are fewer and fewer of them. This may change as where money is placed for education, but also the slack could be picked up by nurses who are trained in multimorbidity, as well as TAs. But one good example of where they are is Meredith Green in San Francisco, which has started a clinic which is aimed at older adults. She is a researcher and a geriatrician and an HIV treating physician. One geriatrician that we work with at Cornell made a comment to me. She said, you know, I think that the ID physician or the HIV treating physician and the client have both aged together and neither noticed that they were getting old. It's aging is a relative phenomenon. And in a recent conference I was at, and a really experienced HIV treating physician, who I'm going to assume was in his 70s, made a comment. He said, people who went into HIV wanted to treat HIV. They didn't want to treat cardiovascular disease. They didn't want to treat osteoporosis. They, God knows, don't want to treat multimorbidity, nor are they trained to do that. And today, fewer and fewer physicians are engaging HIV treatment. So there's a real dilemma here. HIV physicians are not trained for multimorbidity, and there aren't enough geriatricians to go around under any circumstance. So what we see happening is that geriatricians are providing consults. So the primary care physician calls in a consult from a geriatrician. Geriatrician does the consult, works up the case history of that person, and then makes recommendations back to the primary care physician. Great, but the primary care physician is not enacting those recommendations from the geriatrician. Why? The reasons are multitudinous, but that's not where their head's at. That's not where they come from. So you don't necessarily see these recommendations as being vital. Next slide, please. So in work that we do with the American Academy of HIV Medicine, the American Geriatric Society, and ACREA, which first developed recommendations for physicians about how best to manage the older adult with HIV, we came up with a booklet which really embraces geriatric care principles, and we've already gone through like 60,000 copies of this. Next slide, please. And what's important here, I think, and that's part of my take-home message today, and it's only hypothesis, I think that we must go back to empowering the patient. The patient in the late 80s and early part of the 90s, that it was their empowerment, their voices, their insistence on what they needed that brought us to a fairly rapid development of effective antiretrovirals. This is the same issue today. The system has so much inertia, care delivery, that it's incumbent upon the patient to, if you will, rattle the cage, to ask their respective physicians if they're doing the right test, if they're being cautious, if they're looking for certain indications of disease or risk for disease. It's got to happen from, I believe, from the ground up. And I think organizations like NMAC are going to be in a position to do that. This site, I suggest everyone go to, even though aimed at clinicians, anyone go to it. It's free. Last year, we provided CMEs on this site, and there were 10,000 people came to take the CMEs. They were either physicians, nurses, or pharmacists. Pharmacists actually far outnumbered primary care physicians. Next slide, please. This is a booklet which can be downloaded from the site, and at conferences we usually have it. It's a very accessible booklet. One of our colleagues at ACREA is very accustomed to taking difficult clinical language and making it accessible to everyone. Nobody wants to read difficult language, and it's an effective book. I said we've distributed over 60,000 copies. NAC has done it with their HIV and older scholars program. People really, really like this book, and it's also available in Spanish. Next slide, please. Next slide. So there are issues in the background that I just want to allude to. One is disparity. We know they're there, even within small places. In New York City, for example, if you look at life expectancy in the Upper West Side, and then look at East Harlem, look at the difference. It's almost 10 years, if not quite. This is an extraordinary disparity, and it's based upon a lot of issues. One of them are intrinsic issues within the system itself. Next slide, please. We know from other studies that 4 in 5 physicians wish they could write scripts for social resources and social supports. They can't. They don't have time to. They need to have other people make those decisions. And I think that's incumbent not only on the patient, but upon those of you who provide those very important wraparound services. Next slide, please. Remember this, that healthcare does not equal good health. You know, it's like if you go to the doctor and the doctor doesn't write a pill script for you, somehow the doctor failed. No, he didn't. You need to look at health as a whole body experience. We don't always need a pill or some type of physical intervention, whatever. A lot of it has to do with the lifestyle issues that I mentioned before. So healthcare is a sum of many, many parts, which is how best to address multimorbidity. Last slide. My thanks to NAC and to my colleagues at PRIA at GMHC and my faculty at NYU. Thank you very much for your attention.
Yes, thank you so much, Stephen, for that really great presentation. There was a very robust conversation that has been happening in the chat. A lot of yes, we agree, especially about components as it related to social isolation and the impact that's having on the aging HIV population. We did have a couple of questions come up, and we have been taking notes on that on our end. But if you'd like to ask your question over the phone, I know we're nearing around that 4 o'clock time, that 1 hour time frame, but if you could bear with us, we can answer a couple of questions for you all. Just feel free to raise your hand and we can unmute your line. But before we do that, we'll read one of the questions that was in the chat box.
We have one question from Tess Anderson. What role does psychosocial factors play into these modifiable factors? It is all about getting people to a place of wanting to change.
Well, there's a tough question. You know, I think that we know and that peer support, peer-to-peer interactions are critical in changing lifestyle, changing behaviors. And I think that's why, if there's one answer to that, there isn't one, but one of them is to engage other peers, or to engage people who have been successful in, for example, quitting smoking, or changing their diet, or increasing their exercise. Yet some people can do it alone. They have the willpower to do that. Great, God love them. But most people need help, support, and I think looking to peers is an important way, and it gives purpose to all of them.
Thank you, and thank you for your question, Tez. Dina, I see your hand, and I've unmuted your line. Can you hear me? Let's see. Let's try. Well, while we are working on getting Dina's line unmuted, we have another question from the chat box.
Ms. Vicky Lin is interested in understanding the use of medical marijuana for people aging with HIV.
Reality is that there's very little research done on medical marijuana. You know, the government, because marijuana was a controlled substance, didn't allow much, if any, funding from NIH to study its use. So I'm going to wait for the jury to come in. One of my caveats is, you know what? If it works for you, why argue with it? I mean, I would go with it. But I don't think we're looking at any serious toxicities here. But once again, overuse of anything can create toxic issues. But I think the jury's still out about the efficacy of medical marijuana. And again, individual differences can be a primary issue in this.
Should we go to the next one? Another participant is talking about the trauma of living and aging with HIV shows up in a higher rate of substance abuse and depression. He's stunned by the data. Do you think that is some of social isolation?
I think that they two go hand in hand. You know, social isolation doesn't make depression better, God knows. So it only enhances it or makes it worse. And vice versa, depression, if you're inactive or immobile, only will make the social isolation worse. So I think they interact with each other, which is why both have to be addressed.
You know, Dr. Karpiak, I talk a lot about Acrea's research and ROA during my travels in the South, and some people are resentful in the sense that they think that they explain that New York is completely different to the South, and that this ROA data is not as significant for them. What do you have to say about that? Because we had a couple of comments saying that the ROA data was old or only New York City based.
Well, the truth is be known that it is New York City based, and which is why in this iteration of the new ROA 2, we're going to multiple sites. I think that yes, every community may be different, but not radically different. And the data I'm quoting here is not from ROA; it's from many other studies. I sit on a database of almost 15,000 research articles on HIV and aging. So if I have to make an argument for any of these issues, it's not just one data set. In fact, science is never based on one observation, it's based on many. So yes, it's from New York City. Any study that you look at, generally speaking, comes from a specific location. These are samples of convenience. And few studies are huge studies that cover huge populations. They are very expensive and they occur rarely, but it's NIH who really makes those happen. So I agree, but I also agree that resources and circumstances are different in different environments.
I'm aware that ROA 2 is different. Can you tell us more about how ROA 2 is different than ROA 1, and when should we expect the results of ROA 2 to come out?
Okay, so ROA 2, first of all, the biggest difference is, not biggest, but one of them is it's multi-site. Example, in New York City, again, we're doing 1,000, but 300 of those folks are coming from Cornell, where we're pairing their responses to ROA with their electronic health record, which is incredible. We're also looking at rural areas in New York State and small cities. And then we're looking at really a tale of two cities, San Francisco and Oakland. San Francisco, a very different population than that of Oakland. Oakland more represents the general HIV epidemic in the USA. And of course, San Francisco is important because of the historic place in this epidemic. Chicago will come on board, very different than New York, and Minnesota, very different because of the integration of certain subpopulations. So those are, from a sampling viewpoint, very different. The questions in ROA 2 place a lot of emphasis on probing medical issues, but also look at resources. What is it that the HIV older adult thinks they have access to or do not have access to, and what do they need? We're trying to really identify the needs of this population and therefore inform the community, ASOs, CVOs, about how they need to change programs. I mean, think about it. How many AIDS service organizations provide programs for the older population? Very few.
Definitely.
Now, we were able to unmute Dina's line. Dina, but it's showing that you're self-muted. So if you could unmute yourself, we should be able to hear you now. Are you there, Dina?
Oh,
it says
are you
you're
talking to me?
No, I wanted to see Dina Mann. She had a question, but it says that her line is self-muted. Could you unmute your line, Dina?
Okay, I just did. Can you hear me?
Yes, we can. Welcome. Thank you.
I've been working with Alzheimer's and dementia patients, and I wonder how many HIV patients who are older have been experienced the epidemic of acute dementias and Alzheimer's disease.
A great question. Reality is that this population is not that old yet. As I said, their average age is between 59 and 60. So that's pretty young for onset of Alzheimer's. It is being seen, though it occurs at the expected age group, but not enough to make any comments on it. There are cognitive issues in this population, but they are kind of, I don't want to use the word messy, but hard to get a grip on. And I always say to folks, you know, if you have a cognitive issue that's based upon some pathology, or like Alzheimer's or certain dementias, what are you going to do about it? And that's the great mystery or question that we all face, yes, regardless of HIV. And that's where care becomes paramount. There's no way we know to reverse or treat any of the dementias. And more importantly, is to prepare care. But thanks for that question.
Thank you.
Thank you, Dina. And we have another question that came from, I believe, from someone in the chat box here, wanting to know questions about comorbidities and HIV infection disease doctors. How many HIV infection disease doctors are seeking advanced studies in geriatrics and multimorbidities?
A handful. I mean, there are very few physicians trained in HIV treatment and are geriatrically certified.
And Dr. at the beginning of the presentation, you mentioned that you are not in agreement with the hypothesis that people living with HIV are aging faster than the average, the normal population. If so, how would you explain young people living with HIV having arthritis at 50 or knee replacement or hip replacement at 55 when that's something that is more common in your 80s?
Right. So first of all, when you look at enough data, you can find exceptions to every rule. So that's not surprising. But think about it. If you had to look at a study where you wanted to know what was the effect of HIV on the population at hand, the comparison group, the control group, is not just the general population. But you have suffered from stigma, depression. They have been socially isolated. They are Medicaid dependent. They're not working. The list goes on and on and on. It's a very rare find in the research. And all I can say is that at the moment, it's me, but some researchers far more influential than I, do not embrace the accelerated hypothesis. Some people do. You know, there are people who have dementia. When I was getting my PhD, I studied people who are in their 40s with dementia. So does it happen? Yeah, it does. But you have to look at large numbers. And if a person does have, say, a knee replacement at an early age, they probably were already at risk for that for some reason, not just HIV, I would suspect.
Okay, thank you.
Well, that wraps up the general conversation that we were having and the tone of the comments and the questions that we received. I didn't see anybody else with their hands raised. I do want to thank everyone for participating in today's webinar. Also want to thank Dr. Karpiak for his great insight and wonderful information. I really think that it was a great conversation starter and hopefully something that everyone will be able to take back to wherever they live and to have conversations with their providers and also encourage other providers to become engaged in this conversation. So again, thank you so much to everyone who's participating. Thank you so much to our speaker. The webinar has been, and we're also going to be sending out these slides, and we also have additional slides for you provided by our speaker to just wrap around the information so that you can have the most information at your disposal and as many resources as possible. So we look forward to seeing you all next month. We have another one of these webinars scheduled for the first Friday in March, and let's keep the conversation going about HIV in the aging population. Thank you all so much.
And that again, thank you.
Thanks, everyone. Okay.